Yeah.
Welcome to all the IMA leaders of national and state leaders and all the delegates, guest speakers. Welcome to this Indian Medical Association Academy of Medical Specialties monthly webinar. Welcome to all. Today, we are going to have two important day celebration. One is the World Asthma Day and World Hypertension Day. So I thank you IMA leaders for this wonderful opportunity. So today is the 5th webinar of our IMA AMS. This is the program agenda. We'll start the meeting officially with the physician and IMA prayer. May I request Dr. Adar Sindhilkumar for the IMA and physician prayer.
Kindly share the slide, sir.
Yeah, please see.
Sir, very good evening. Physician prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow man, and a true realization of the rare privilege that is mine. Take from my heart all the will and worldliness, that with the simple faith of a child I rely on thee. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you, sir.
Thank you. May I request our chairman of IMA AMS, Dr. Rajesh Babu sir. Rajesh Babu sir is a senior consultant neurosurgeon in and HOD, head of the department in Ganga Hospital. Dr. Rajesh Babu sir is a former president of IMA Coimbatore and currently chairman of Organization Committee of IMA TNSB for the welcome address. Over to Rajesh Babu sir.
Good afternoon, everyone. Today, we are having the May month 5th IMA AMS CME. I thank our state president, Dr. Abul Hassan sir, for giving us the opportunity to conduct the program. I like to welcome you all for the program. I welcome our president, Dr. Abul Hassan sir, the state secretary, Dr. Kartik Prabhu sir, the state the past president, Dr. T. Sandavil Pari sir, and national vice president, Dr. R. Gunasagaran sir, and state president-elect 2024, Dr. Sengutuvan sir, and state president-elect 2025, Dr. Sridhar sir. Today, we are going to have the, I welcome also the national leaders, the Namita Gupta madam, the chairman of IMA AMS, and Dr. Srirang Abgari, the secretary from Hyderabad. Today, this month, we are having this CME on asthma and the hypertension day celebrations. And we are going to have the nice speakers today. And I welcome the moderators and speakers. The speakers, Dr. Sridevi and Dr. A. Muruganathan sir, and the moderators, Dr. Nalini Jayanti and Dr. Seniyappan sir, for the today's CME. Actually, in the IMA AMS, we are going to have the AMS courses. And next month, we are going to start a course on the laparoscopy course, which is called LAPIMA 2024. From Coimbatore, they are going to do it. And within 10 days, we will be launching the program. At that time also, we will be having a CME like that. And then we will launch the program. And we are thinking in terms of conducting other courses also in the various departments. I am having discussion with all the people. That is the main thing. And I request, here we are having around 236 participants. I request all the participants, those who are not become the member of the AMS, which is the Academy of Medical Specialties, I request them to please join the IMA AMS wing, because the registration fee is only 1,186 rupees, 80 rupees only. And regarding the main program which we are going to have is in the month of June 9th, we are going to have the State East Zone IMA-AMS conference at Trichy. And in the month of the July, we will be having the IMA-AMS National South Zone Conference. Previously, we announced the date as the 14th, and because of some administrative reasons, the meeting is, the conference is postponed to 29th of July. That we will be coming out with a brochure and all those things, and which will be conducted by all the branches of IMA Chennai. So I invite you all for the East Zone meeting in Trichy in the next month, and also to the National South Zone Conference at Chennai. I welcome you all once again. Thank you.
May I request our State President, Dr. Abul Hassan sir, for the presidential and the felicitation speech. Over to Dr. Abul Hassan sir.
Good afternoon, all of you. Thank you, Dr. Jayaraman, Rajesh, and Adar Sindil Kumar. And I respect the faculties of today's webinar, Dr. Sridevi, Dr. Nalini Jayanti, Dr. Chenniyappan, and Dr. Muruganathan, the national office bearers, Dr. Namida and Akbari, our own office bearers, Dr. Sundutwan, Sridhar, and all the office bearers of AMS today. I congratulate AMS wing of IMA Tamil Nadu State Branch for combining these two important days events on asthma and hypertension with exciting and very popular, exciting topics with the popular faculties, Dr. Chenniyappan, Muruganathan, Sridevi, and Nalini. I think it will definitely help our delegates who are joined today with lots of messages on these two important diseases in the society. And I think I would like to share one important additional information that even people in other states and are showing interest in joining these kinds of meetings. And of late, we have taken up measures to start overseas branches of IMA Tamil Nadu State Branch, comprising our Tamil doctors who are working in Gulf region, in UK and also US. And we have already started work in this regard. We had one preliminary meeting with the important people of those countries, myself secretary and finance secretary. In another month time, it will be fruitful so that they will also be joining our meeting from their countries. And they showed a keen interest when I was telling them about our academic events that are happening every month in various platforms, be it CGP, AMS, or academic committees. They were very excited about it and they wanted to attend it, but also because of these credit points we give them for renewing their registration in our Tamil Nadu State Medical Council. So that will be another boost for our academic event. And I saw there was lots of academic events lined up for this month, June and also July. Of course, additionally, we will be having Doctors' Day meeting. All these events should not go waste. In the sense, what I mean is, all these things can be edited and have a kind of a digital library, so that anytime we can circulate these topics and talks, people will be immensely benefited even after we conclude our, finish our meetings. And I wish IMA-AMS to go to higher and higher levels and conduct these kinds of meetings. And our AMS is doing a wonderful job. Congratulations to you again, once again, and I wish all the delegates have a very good time. Thank you very much, Dr. Jayaram. Over to you.
Thank you very much, sir, for your wonderful advice. We'll follow all your advice, everything, sir, for all our welfare of our members, and ultimately we are helping the patient. Thank you very much, sir. Thank you, sir. Now I'll give my secretary's report. I'm Dr. S. Jayaraman. I am a AMS Secretary of TNSB. So we have the team of Chairman, Dr. V. Rajesh Babu sir, and Joint Secretary, Dr. Adar Sendil Kumar. So thank you for this wonderful team. So this is my brief activities in the month of April. So 4th April, we did a 4th webinar to commemorate World Autism Day, Malaria Day, and Parkinson's Disease Day. So we have a lot of stalwarts throughout Tamil Nadu, speakers and moderator, to explain detail about all the updates in autism, malaria, and Parkinson's disease. And 7th April, we have a World Health Day. The theme of this day is My Health and My Right. So I did a Facebook Live program for our general public, so about all the health aspect, the preventive aspect, etc. And we had the video clipping released from our IMA-AMS. So on the commemoration of World Health Day, again the theme of My Health and My Right. And in the month of April 13th, so we had a new branch inauguration at Chennai, IMA-AMS Chennai South branch. Our chairman, Dr. Rajesh Babu sir, and myself participated as a guest of chief guest and guest of honor. And we took part in that semi program organized by the IMA Chennai South in association with the MGM Healthcare, Malar Adayar branch. So myself and Rajesh Babu sir participated as a chief guest and guest of honor. So we had a wonderful update on the cardiovascular disease and the minimal access daycare surgery. And in my own branch of IMA Chennai Biologics, we had a IMA-AMS monthly semi meeting. So we had a wonderful talk by Dr. Gunasekaran about jaundice and salvaging chest pain advances in management, total arterial revascularization by the Prasant Hospital doctors, and we had a wonderful discussion. In Chennai, IMA-AMS Ambattur Avadi branch conducted the program, semi program on decoding the head and neck region. There are two eminent speakers spoke about minimally invasive head and neck surgery, robotic assisted surgery, and recent advancement in the field of oral and maxillofacial surgery. Again, in Coimbatore, IMA-AMS wing conducted along with the CMS College of NSS wing health awareness program on the topic of hypertension and kidney disease by Dr. Prabhakaran at Carl Gruber Institute, Anaikatti on 28/4/2024. It was well attended by around 75 people. So this was the meeting plans, semi program, AMS wing of IMA Coimbatore wing. And usually this is our brief handout about our IMA-AMS. In this, all the points about what is the objective of IMA-AMS and the physician prayer, IMA prayer and flag salutations, and all the fee structure, everything in all about in the handout. So we wherever we go, we circulate to all our members. So these are all our main commandments, aim of our AMS. The first main aim is to increase the life membership. There is a one-time life membership fee is 1,180 rupees only. So this is a lifetime membership fee. And each and every branch has to have the IMA-AMS wing. Like a College of General Practitioner wing, we have to have the Academy of Medical Specialty wing in each and every branch. So this in Chennai, recently we started the first branch in my own Villivakam branch. So we did a regular IMA semi program under the banner of IMA-AMS and a lot of awareness program for public also. This branch 2 inaugurated in Tiruvallur branch, and myself attended as a guest chief guest. We inaugurated the IMA-AMS of Tiruvallur branch. And the Ayambakkam Kodambakam, that is IMA Kodambakam branch, we have inaugurated AMS wing. So I participated as a chief guest, and I delivered lecture on Indoman oration in the IMA Kodambakam branch of AMS. And branch 4, the Chennai South, already mentioned about that. Our chairman Rajesh Babu sir participated as a chief guest, and we have inaugurated, and the CME was conducted. So these are all the main courses this year we are going to start, like ophthalmology, spine surgery, upper GI endoscopy, laparoscopy, rheumatology, oncology, interventional pulmonology and thoracic oncology, and intensive critical care. This is the master class we do regularly. 2 months back, we did a master class on sleep at MGM Healthcare. This is organized by the IMA-AMS wing of Chennai Villivakam branch. And we had a master class on adult vaccination. Again, IMA-AMS Chennai Villivakam did this master class for our members, IMA members. And we have the observership program for all our members, those who want to improve the knowledge of the particular field. So we allot hospitals like super specialty hospitals. We do the 3 months to 6 months training program, observership program and all. I request every members kindly join AMS and utilize this opportunity. And we are going to conduct the East Zone Conference of IMA AMS at Trichy on 9/6/2024. This is our national conference on IMA AMS South Zone. So Rajesh just now said instead of 14th July, 29th July we are planning. The theme of this program is recent trends in specialties. So this is the brief first announcement brochure. The date will be changing into 7th month. I will update all the things in very soon with the brochure and other details and all. So every month we do the TNMC CMA credit point hours for our monthly meeting for our members' benefit, and every quarterly during our state council meeting we release the Tamil Nadu AMS news bulletin. We released 2 months back in Yelagiri, our state council meeting. So with that, I conclude my secretary's report. May I request chairman of IMA AMS, Dr. Numita Sivagupta ma'am, so for the felicitation address. Over to Dr. Numita ma'am. I think ma'am is traveling, I believe. Anyway, may I request our honorary secretary of IMA AMS, Dr. Sirang Akbari sir. Sendil sir, please check. Sir is available there.
It's not technical call, sir.
Okay. May I request our National Vice President, Dr. R. Gunasekharan, sir?
Yes. Good evening. Good evening, everyone.
Good evening, sir.
Welcome.
Good evening. Respected State President, Dr. Abul, State Secretary, State Treasurer, and all the President-elects, Dr. Sridhar Sengutuvan, and Chandamel Pari, the immediate past President, Chairman of IMA AMS, Dr. Rajesh Babu, Secretary, Dr. Jayaraman, and Joint Secretary, Adar Sendil, and all the AMS office bearers and other leaders of IMA. It is a nice day. We are celebrating the World Respiratory and also the Hypertension Day together. Usually, these AMS organizers, they combine the one of the national health days with the topics. It is nice of them that today it is important topics, especially on asthma and hypertension, which is very useful for all the general practitioners, not only for the physicians, and all the general practitioners. You should know about the intricacies and the diagnosis and treatment about the present day therapy of asthma. The Dr. Jayaraman himself is a senior of respiratory physician. So he is there to enlighten us anytime when we want. Today, the stalwarts in cardiology, the Dr. Chennappan, my good friend from Trichy, is going to moderate a session on hypertension. Our senior leader in API, Dr. Muruganathan, is going to talk about hypertension. And we are here to hear the topic and get benefit. At this juncture, I also invite all the delegates here, more than nearly 300 people are here. I request you to come to Trichy for the East Zone AMS conference on 9th of June. With this, I congratulate the team AMS for the wonderful program today. Thank you.
Thank you. Thank you very much, Gunasekharan sir. We are all will be there in Trichy, our East Zone conference on 9th June. Thank you very much, sir. May I request our State Honorary Secretary, Dr. Karthik Prabhu, sir? May I request our State Finance Secretary, Dr. Gauri Shankar, sir? Our immediate past President, Dr. Chandamel Pari, sir? I think Pari is traveling, I believe. May I request Dr. Sengutuvan, sir, President-elect of 2024? That is having some net issue. May I request IMA TNSB President-elect 2025, Dr. B. Sridhar, sir?
Yes, Jairam, thank you so much. Most respected President, Dr. Abul, Secretary Karthik, Treasurer Gauri Shankar, and the office bearers of AMS chapter, Dr. Rajesh Babu, Dr. Jairam, the excellent speakers waiting to give us a wonderful knowledge explosion, and the moderators, the most respected people, and all the members who are keen to listen to what the speakers have to say, along with the national leaders, Dr. Gunashekaran and Chairman and Secretary of the National AMS. It is a great opportunity for people who do not belong to these specialities to have a first-hand knowledge of the updation of what is available in the treatment of hypertension and such things. I'm also very keen to listen to what the speakers have to say. So I offer my felicitations to all the people who are involved, especially the AMS team, which has been doing a wonderful job through these webinars, and the state office, which is giving enormous support for the successful conduct of the same. And I wish the speakers and the moderators and they're definitely all the audience who are waiting to listen will gain a lot at the end of the day. And I felicitate the whole team for the success of this program. Thank you, and over to Dr. Jayara.
Thank you very much, sir. Definitely will follow all our advice, sir. Thank you. Sendil sir, shall we move on to the CME program?
I'm still link touch
Rajesh Babu sir, shall we move on to the CME program, sir?
Sir,
Yes, sir.
Karthik Prabhu sir ulla varar sir.
Yeah. Welcome, Dr. Karthik Prabhu sir, our state honorary secretary. Karthik Prabhu sir.
இப்பதான் சார் ஓபன் பண்றாரு. சொல்லிட்டேன். Sir, waiting.
Sendil sir, please check Dr. Nomita ma'am, assistant advisor is there. Just open the no.
சார் ஆட் பண்ண சொல்லுங்க சார் கார்த்திக் பிரபு சார். சார் கார்த்திக் பிரபு சார் கோஹோஸ்ட் பண்ண சொல்லுங்க.
ஓகே, அவங்க ஜஸ்ட் அன்மியூட் பண்ணணும்.
நீங்க அன்மியூட் பண்ணி பேசுங்க சார் கார்த்திக் பிரபு சார்.
வெல்கம் கார்த்திக் பிரபு சார், Honorary Secretary of our AMS Terminology chapter.
Unmute பண்ணி பேசுங்க சார். Program sir.
Now we'll start the CME program. Today we're going to have the two important days commemoration. One is the World Asthma Day. So the topic of the talk is the current diagnosis and treatment of asthma as per the GINA, Global Initiative for Asthma Guidelines. For that, may I welcome moderator Dr. Nalini Jayanti ma'am. Dr. Nalini Jayanti ma'am is a professor and head of the Department of Respiratory Medicine in SRM Institute of Science and Technology. Madam did MBBS from Stanley Medical College and DTCD and MD from Madras Medical College. And initially he worked as in Chengalpattu as associate professor, then became the professor in Stanley Medical College and Kilpack Medical College, and professor and medical superintendent of the Tambaram Sanatorium and Oteri TB and Chest Hospital. And Madam is examiner for various universities. Madam is the faculty in all our national conference on TB and chest diseases like NAPCON, NETCON. And Madam is one of the very active member of our IMA, Indian Medical Association. And Madam took part in TIMACON, Tamil Nadu IMA conference in Chennai. It was a 2022 conference as one of the organizing committee team. Madam is one of the leader of our IMA Perambur branch. So with this intro, may I request Dr. N. Nalini Jayanti ma'am, over to you and kindly introduce the topic and the speaker ma'am. Nalini ma'am, over to you.
Yes. Am I audible, Dr. Sanjay Raman?
Yes, ma'am. Yes.
Thank you for the introduction. Good afternoon to one and all IMA members, state office bearers, as well as national bearers. Today, Dr. Jayaraman said, okay, we will do a topic on World Asthma Day. When we talk about World Asthma Day 2024, now the theme for World Asthma Day that says Asthma Education Empowers. So he has taken a right topic to empower education to all the general practitioners who are sitting in various state level like south of Tamil Nadu regarding, because everybody handles an asthma patient. So we usually say Global Initiative Asthmatic, like GINA, we say Global Initiative for Asthma, the GINA guidelines that says 2023, and a lot of changes have happened. Every year we have some guidelines which are coming up. And for this I invite Dr. Sridevi, who is going to be a speaker on this. She is a consultant pulmonologist. So she will be doing on this particular subject. She is from Jericare Hospital. She is a renowned speaker. So we'll see what she is going to tell from the GINA guidelines. This is entirely from a global initiative for asthma guidelines. So then we'll see how to proceed. Yes, Jayaraman, you want to introduce Sri Devi? Or do
Yes,
I
ma'am.
have...
Nalini Jayanti ma'am, for your kind introduction. Good afternoon, everyone. At the outset, I would like to thank IMA, AMS Wing and the entire team behind organizing these webinars. I think it is like indeed my honor to be participating, to be presenting in this forum. Thank you, Jayaraman sir. So without any further delay, let's get started. Today's topic being current diagnosis and treatment of asthma. So mainly we'll be concentrating on the GINA guidelines. GINA 2024 guidelines are yet to be released. So I'll be focusing all the guidelines like, main important changes which happened till GINA 2023. So GINA stands for Global Initiative for Asthma. So as you all know, World Asthma Day is observed on the first Tuesday in the month of May to raise awareness about this very disease worldwide. And this year's theme being Asthma Education Empowers. And this is to emphasize the need to empower people with asthma with appropriate education and to manage their disease accordingly and to recognize when to seek medical help. And GINA is doing a wonderful work in this regard. GINA stands for Global Initiative for Asthma. It was established in the year 1993. And since almost more than 30 years, they've been guiding us with new updates every year. And they're working with the healthcare professionals and public health officials around the world. And their main aim is to reduce the asthma prevalence, mortality, and morbidity. So briefly about the definition of asthma by GINA. So asthma is a heterogeneous disease which is characterized by chronic airway inflammation. So which causes symptoms such as wheezing, shortness of breath, chest tightness, and cough. And the most important thing is these symptoms vary in frequency and intensity. And together there's variable expiratory airflow limitation. Now, this is the brief outline of the pathogenesis of asthma. So as soon as the antigen enters the body, the main cell, the first cell to come in contact is a dendritic cell, which sort of presents this to a naive T lymphocyte, which differentiates along Th2 pathway. And here you can see it is differentiating along Th2 pathway. And this results in release of lot of inflammatory cytokines, mainly being interleukin-3, 4, interleukin-13, and these are responsible for recruitment of the inflammatory cells, mainly mast cells, basophils, and eosinophils. And even IgE is also released in large amounts. So what happens is when these mast cells, basophils, eosinophils, they kind of rupture, they cause the degranulation and release of these inflammatory mediators, mainly histamine, prostaglandins, leukotrienes, etc. And these are responsible for the airway spasm, the bronchospasm, and thereby causing all the symptoms what we see in a patient with asthma. Now, this is how the airway of a normal person looks like. It is quite roomy, whereas here you can see the airway of an asthmatic patient. It is quite narrowed, and especially during an acute attack, it is the airway lumen is further compromised. So this happens mainly because of a lot of factors, one being bronchospasm. Secondly, there's a lot of mucus in the lumen, as you can see, the submucosal, deposition of a lot of the fibrous tissue and mucosal gland hyperplasia. And finally, it leads to a kind of airway remodeling. So the airways are severely compromised in a patient with asthma. Now, the signs and symptoms which a patient with asthma presents would be cough, breathlessness, chest tightness, wheeze. And the most important thing, as I told you, is they are variable. So there could be a diurnal variation. And if the patient has symptoms since many years, there could be seasonal variation. And a particular trigger is always present whenever these symptoms are present. And there's also a significant family history and a personal history of asthma or atopy. And on auscultation, bilateral expiratory polyphonic wheezes are heard. The main investigations what a patient, presenting with the typical symptoms of asthma should undergo include a complete blood count, mainly focusing on the eosinophils and absolute eosinophil count and serum IgE levels. These are the biomarkers which are important in a patient with asthma. So what do they mean? Whenever these markers are increased, so probably the patient is responds well to inhaled corticosteroids. And of course, the spirometry with a reversibility testing is important. Chest X-ray, FENO test if is available, ECG and echo. ECG echo is important if at all the patient is presenting elderly, patient is presenting with a wheeze for the first time, to rule out if there is any cardiac component. Now, this is a spirometry. What you see two graphs. One is a flow volume loop. This flow volume loop, above the x-axis, you have what is known as expiratory limb, and below that is the inspiratory limb. What you're seeing here is a normal flow volume loop. On the left-hand side, the volume time curve is seen. This is to show how many seconds the patient has blown out. And normally, patient has to blow out for at least 6 seconds. And in this graph, you can see how the asthmatic airways, there's a lot of cooing, or you can see a scooping out of the expiratory limb. So this happens because of severe airflow obstruction. And the main parameters what you are going to take into consideration include FVC, FEV1, and the ratio. So mainly the ratio and FEV1 are severely decreased in a patient with asthma. So any patient with reduced values of FEV1, FVC ratio with FVC, you're going to subject them for something known as a post-test and a reversibility testing, wherein you're going to administer the patient with a short-acting bronchodilator like salbutamol and wait for, say, 15 minutes and repeat the test to see if the airways are, the parameters are increasing or if there is any improvement. So any improvement in the FEV1 value, especially by 12%, and an increase by 200 ml in FEV1 is diagnostic of asthma. So uses of spirometry, it is not only useful in diagnosing asthma, wherein by doing the reversibility testing, if at all, if it is improving, definitely that shows that the patient is having asthma. If the patient don't reverse after giving a short-acting bronchodilator, so probably we are dealing with COPD. And also it is useful in monitoring the response to therapy. So say you're repeating a spirometry after starting the patient on the treatment. So probably if they are improving, so to see the monitor, the response to therapy also, it is useful. Now, chest X-ray, usually the asthmatic patients have a normal chest X-ray, but you have to take a chest X-ray to rule out if there is any underlying disease or if there is a pneumothorax or any other infection going on in the lungs. So to rule out other conditions, you have to take a chest X-ray, and sometimes a chronic asthmatic patients may have hyperinflation of the lungs as well. So FENO test, FENO stands for fractional concentration of exhaled nitric oxide. So what is this nitric oxide? It is a gas which is produced by the inflammatory cells, which are associated with allergic or eosinophilic asthma. So this is similar to the spirometry. The machine looks almost similar to a spirometry. All that the patient has to do is breathe in and breathe out through a probe for, say, 1 minute, and then you're going to measure what is the exhaled nitric oxide value. And the normal value being less than 25 parts per billion. Now, whenever the FENO value is high, say in adults, more than 50 parts per billion is considered to be a high FENO value. And in children, anything more than 35 itself is considered to be a high FENO value. So what does this indicate? So this means that the patient is having a type 2 inflammation, and they will respond well to inhaled corticosteroids. Now, this is sort of the diagnostic algorithm, wherein the diagnosis of asthma starts with a good history taking, examination, and you perform a spirometry test. If at all the patient is having a good reversibility, then you have the diagnosis and you treat the patient accordingly. If the patient doesn't have typical symptoms of asthma, the spirometry is not suggestive of asthma, then probably you may have to investigate the patient further. Now, phenotypes of asthma. So broadly, you can categorize them as allergic asthma and non-allergic asthma. Allergic asthmatic patients, they have mainly type 2 kind of inflammation, and which is associated with high eosinophil counts, high FENO values, and they usually respond well to inhaled corticosteroids. Whereas non-allergic asthma, it is associated with high neutrophil counts and they are steroid unresponsive. So this can be associated with acute or chronic infections, obesity, smoking, irritant exposure, etc. And non-allergic asthmatic patients, they behave more like COPD patients. So after you have diagnosed a patient based on the history and findings and all the investigations, how do you manage them? So management includes a continuous cycle of assessing the patients, adjusting the medications, and continuous review of the patients. Now, the main medications for an asthmatic patient include two broad categories. One is a reliever medication and the other one is a controller. So relievers, what do? They give quick relief of symptoms. So under this category, we have SABA, which is short-acting beta-2 agonist. Under this, salbutamol and terbutaline. So short-acting anticholinergics like ipratropium bromide is included under reliever category. So formoterol, as you know, it is a long-acting bronchodilator, but it can be given as a reliever because it has rapid onset of action. So ICS formoterol, like beclomethasone formoterol or budesonide with formoterol, can also be used as relievers. Now, controllers. So controllers are the drugs which prevent future exacerbations. Under this, we have two main categories. One is LABA, which is long-acting beta-2 agonist, and ICS, which is inhaled corticosteroids. So LABA, under this, we have salmeterol, formoterol, and vilanterol. So salmeterol, formoterol, they kind of act for 12 hours and may need twice daily dosing, whereas vilanterol is an ultra-LABA, which can act even for 24 hours. Now, the other category of controllers include inhaled corticosteroids. And under this, we have beclomethasone dipropionate, budesonide, fluticasone propionate, fluticasone furoate, and cyclisonide. Now, usually ICS is clubbed with LABA. They come as combinations for the patient's benefit. So budesonide formoterol, or you can have a beclomethasone formoterol. Fluticasone propionate can be clubbed with salmeterol or formoterol, and fluticasone furoate can be clubbed with vilanterol. This is a newer one. Now, as you know, all the asthmatics, they're given the medications not in the form of tablets, but in the form of devices, which are known as aerosol delivery devices. And this could be in the form of nebulizers, meter-dose inhalers, dry powder inhalers, or if the patient is not able to use meter-dose inhalers because it requires hand-mouth coordination, if the patient is not able to take it that way, then you can club them with what are known as the extension devices, the spacer devices. Now, you have a wide variety of devices in the market, and it is so important that you choose the right kind of device for your patient and also teach the right technique. And this will not suffice. It is also important to reinforce the technique when they come for the follow-up. During each visit, you have to check the technique so that the patient, make sure that the patient is using them correctly. Now, according to GINA 2023, so the asthma medications, the patients are started on two tracks, like either track 1 you can choose for your patient or track 2. So track 1, it includes steps 1 to 5, and track 2 also consists of steps 1 to 5. Step 1 and 2, it is like mild asthma patients have symptoms now and then. So you can give them what is known as the reliever, which is anti-inflammatory reliever therapy, which includes ICS+LABA. Straight away, you're going to start the patients on ICS+LABA whenever required. So whenever they have symptoms, they can take it. So in the track 1, step 1 and 2, you're going to start the patients with low-dose ICS formoterol, which is a combination drug. And then in step 3, you're going to maintain them. So step 3 to 5, you're going to maintain, use a MART therapy, which means maintenance and reliever therapy with ICS formoterol. Step 3, you're going to use a low dose maintenance ICS formoterol. Then step 4, it's a medium dose ICS formoterol. And step 5, it is a high dose ICS formoterol. So step 5 patients, if they are not, the symptoms are not coming down with a high dose ICS formoterol, then you can add a LAMA or consider the patients for biologics. So track 2 here, if certain patients or the physician feels that they don't want to use a LABA straight away for the mild cases, then they can use a SABA as well. But they have to use, the patients should use ICS whenever they're taking a SABA. So they should have kind of 2 inhalers with them. So SABA they can take whenever required, whenever there are symptoms. But at the same time, you are going to ask the patient to use ICS. So whereas step 3, you're going to maintain the patients with low dose ICS. Step 3 to 5, it is more similar to track 1. So why this changes came up? So these changes came up in 2019 GINA guidelines that SABA alone is no longer recommended. So prior to that, I think mild asthmatic patients, most of us must be using just a SABA therapy. So if the patient doesn't have much symptoms, so they can use whenever required a short-acting bronchodilator. But a major change came about in 2019 guidelines, wherein they said that SABA alone therapy should not be recommended for any patients, even if they have mild asthma. So what are the reasons for this? So they came up with these guidelines because even mild asthmatics are at risk of exacerbation to the extent of almost 30 to 37%. And almost 16% can have near fatal asthma, and 15 to 20% are at risk of asthma deaths, as the triggers are unpredictable. So, and also another reason being continuous use of short-acting bronchodilators. What happens is the receptors are sort of occupied always. So there's kind of down regulation of the receptors. And as the patient keeps taking them, only the side effects will keep increasing and the protection from the exacerbation decreases. On the other hand, if you're going to include ICS, so ICS, as you know, inhaled corticosteroids, they decrease inflammation, because asthma is not only about the bronchospasm, there's a lot of inflammation which is going around. So to target that, you have to start the patient on inhaled corticosteroids. And also ICS reduces the hospitalizations and asthma deaths. And also the requirement for oral corticosteroids can be reduced. Now, all the patients who have been started on the treatment also should have something known as asthma action plan in place. So what does it include? It includes patients' usual asthma medications, when and how to increase the medications, and when to start oral corticosteroids, and when to access the medical care if symptoms fail to respond. Now, this can be a way in which an asthma action plan, you can ask your patients to follow green zone, yellow zone, and a red zone. So green zone, you can ask the patient to, take the usual medications. If the patient has seen you as a on the OPD basis, doesn't have much symptoms, you can start the patients with the medications, the dosage, and the duration. So if the patient has slight symptoms and the peak flow reading is kind of falling, then you can include, the medication, ask the patient to start the medications in the yellow zone. You can put in the chart like to start these medications. And if the symptoms are worsening and the peak flow reading is falling further, then you can ask the patient to start few medications. And then that is the time when they have to contact the doctor, seek the medical help. They have to come to the OPD or the emergency if required. So this has to be given for all the patients. Some emergency medicines has to be put up. It's not only the oral command, but you have to write it down. You have to tell them when they can start these medications. And also some emergency medicines has to be put in your prescription to make sure that they don't have a fatal exacerbation. And also all the patients who have moderate or severe asthma, I think this is a great device. I think they can monitor their lung functions at home itself. The peak flow reading can be done at home itself, morning and evening readings, and they themselves know when is their best reading. And if the PFR is falling, and that is the time they know there's an impending exacerbation, and that's a time to seek the medical help. So this has to be advised for all the patient to maintain a record, especially in the patients who have moderate to severe asthma. Now, few of the terminologies, it can be confusing. So let's see what these mean. So uncontrolled asthma, difficult to treat asthma, severe asthma, and exacerbation. So whenever a patient is coming for the follow-up, I think you should know how good their asthma is under control. For this, you can have a brief questionnaire in your OPD itself, like, say yes and no questions, like daytime symptoms more than twice a week, any night awakenings due to asthma, need for reliever medications more than twice a week, and any activity limitation due to asthma. If the patient says they don't have any of these symptoms, so probably the patient's asthma is well controlled. And if they have like one or two of these symptoms, their asthma could be partly controlled, and the patient has all these symptoms or at least 3 of these symptoms, so their asthma is uncontrolled. So any patient having all these symptoms, so they have uncontrolled asthma. So uncontrolled asthma, they have poor symptom control and they have frequent exacerbations. Now, what is difficult to treat asthma? So difficult to treat asthma is asthma which is uncontrolled despite GINA step 4 or step 5 treatment. So step 4 treatment, we saw it was a moderate dose of ICS formoterol. And step 5 is a high dose ICS formoterol. So in spite of that step, if the patient's symptoms are not getting under control, so that is difficult to treat asthma. So how do you manage uncontrolled or difficult to treat asthma? So first, in most of the patients, it will be, the treatment related, to the treatment issues. Like, you have to check the inhaler technique, just see if they're using it correctly and see if the inhaler is, the doses are still remaining. Most of the patients, they'll be using the inhalers even after the doses are over. So all those things, the correct technique has to be taught every time they come, and make sure they're using it correctly. And also check if the patient is experiencing any side effects related to the treatment. Most of the patients can have oral thrush or some taste alterations, and that could be the reason why they may not be using. And also make sure that the patient has asthma action plan, written one in place. And also assess if the patient has any risk factors, any exposure to triggers, particularly the allergens, indoor, outdoor, any recent infections, occupational sensitizers, tobacco smoke, air pollution, food, weather, exercise, drugs like aspirin, beta blockers. So all these also could be the reason why their asthma is not getting under control. And the next important thing is the comorbidities. So, which includes rhinitis, rhinosinusitis, nasal polyposis, gastroesophageal reflux disease, vocal cord dysfunction, obesity, OSA, depression, anxiety. So once you target all these things, most of the patients with difficult asthma, when you target the treatment issues, comorbidities, and the triggers, then their asthma will be much more manageable. Now, what is severe asthma? Severe asthma is in fact a subset of difficult to treat asthma, wherein you have, tried to kind of manage all the contributory factors, and, patient is, adhering to the therapy well, and you've given the maximal optimized therapy to the patient. So in spite of that, the patient's asthma is not getting under control. So such group of patients, you categorize them as severe asthma. So what do you do with such patients? So you have to add-on controllers, and this is the place where you can consider biologics. Now, what are these add-on controller medications? So the long-acting anticholinergics like tiotropium can be added, and some patients you may need to add leukotriene receptor antagonists like montelukast, and also consider adding steroids, a short course of IV or oral systemic corticosteroids. And a certain group of patients, you may have to add azithromycin as well. Now, biologics. So what are these biologics we've been talking about? So biologics are nothing but the monoclonal antibodies that act at specific targets. In the first few slides, I showed you, like, there are a lot of inflammatory mediators like, IgE, IL-4, 5. So these biologics kind of target those specific sites, and they kind of help in reducing the inflammation, making asthma much more manageable. Now, what are the indications? So you have to choose your patient for the biologics. You cannot start these biologics upfront in all the patients with asthma. Only a certain small subgroup of patients need to be on these biologics. So which includes severe allergic asthma. So you have to take some biomarkers into consideration before starting the patient on biologics, which include absolute eosinophil count, serum IgE levels, FENO values, and only if these values are high, so probably they are the patients which can be started on biologics. So what do we have? What biologics do we have in market? The first biologic which was approved by FDA was way back in 2003. which was omalizumab. It is anti-IgE. As you all know, anti-IgE is a molecule which kind of bridges to mast cells and causing the degranulation. So it acts at that site, blocking IgE. And this can be used in the age group more than 6 years, and IgE value should be in the range of 30 to 700, and the dose should be like 75 to 375 mg subcutaneous every 2 to 4 weeks. Now, more than 12 years later, we got another molecule, biologic, which is mepolizumab, which was FDA approved in 2015. It is anti-IL-5. So it is can be given in the patient more than 6 years of age. And again, you have to take into consideration absolute eosinophil count. It is given in the age group, it is given in the dose of 100 mg subcutaneous every 4 weeks. Now, another molecule which came the very next year was reslizumab, which is anti-interleukin 5. Again, it is anti-interleukin 5. It is given as an infusion. And here, age more than 18 years are the patients where you can start these infusions. And benralizumab, which was FDA approved in 2017, which acts at anti-IL-5 receptor. So here it is given as 30 milligrams subcutaneous every 4 weeks for the first 3 sessions. And from then on, you can use it as every 8 weeks. Next molecule is dupilumab, which came in 2018, which acts at anti-IL-4. And here again, it is given in the dose of 200 mg subcutaneous every 2 weeks. Now, most of these biologics are safe, but they do have certain side effects because they are injections. So all the injections, there is a fear of anaphylaxis always there, and injection site pain, and sometimes headache can be there. Now, the newer biologic molecule, what we have now is tezepelumab, which is thymic stromal lymphopoietin, which was approved by FDA in December 2021. So it is given in the dose of 210 milligrams subcutaneous every 4 weeks. So unlike the other biologic molecules, advantage of this is you don't need the allergic asthma to be present. It can work even in non-allergic asthma as well. Now, we saw all the terminologies. So what does asthma exacerbation means? So asthma exacerbation is an acute episode of progressively worsening shortness of breath, cough, wheezing, and chest tightness. So this is a slide showing how do you manage an exacerbation. So you have to always classify if the patient is walking into the emergency room, just make sure whether you're dealing with a mild, moderate, severe, or a life-threatening asthma. So definitely severe and life-threatening asthma, they need ICU admission. But mild to moderate asthma, like if the patient is talking in phrases and their pulse rate is anywhere between less than 120. And saturation is above 95, and the PEF reading is more than 50% of their predicted values, then you can start them on short-acting bronchodilators every 20 minutes for 1 hour, and then you can reassess. Also, at the same time, you can start them on prednisolone as an oral tablet or an injectable, and you can give them controlled oxygen therapy as well. So if the patient is getting better, then you can discharge the patient with the prescription. Otherwise, they also need admission. So severe asthma, here the patient talks in words and the respiratory rate is more than 30 per minute. All the accessory muscles are in use and pulse rate is more than 150, and saturation is also not looking great. It is less than 90. And so such patients definitely manage in ICU. And life-threatening is when the patient is almost drowsy, confused, and the silent chest. Definitely ICU requirement is there. And such patients, what do? You have to nebulize them continuously with short-acting bronchodilator and ipratropium bromide. Give them controlled oxygen therapy. Consider, systemic corticosteroid as an injection. You can give them, and you can also have, take a blood gas analysis. If the patient's carbon dioxide is way too high, then you can start them on non-invasive ventilatory support. Or sometimes, like if they're really acidotic, then most of the patients may need a certain group of patients may also need intubation. Now, and once you stabilize them, if the patient is getting better, then you can step down the medications, shift to the ward, and arrange for discharge. And it's important to follow up such patients within 2 to 7 days itself to make sure that they're doing well, taking the prescription correctly. Now, take-home message, like this year's asthma theme being like, asthma education empowers. So I think we have to take this seriously and educate all our patients regarding asthma. And, you have to tell them regarding avoidance of triggers, allergens, smoking, also weight reduction and maintaining a healthy diet is important, and treatment of all the comorbidities. Check the inhaler technique, their adherence, have the asthma action plan in place, and self-monitoring of symptoms with a peak flow meter has to be done, which has to be told to the patient, and regular medical review with periodic spirometry should also be done, and consider biologics only in case of a small group of severe asthmatics. And also, we all know the importance of vaccines, so all these points have to be taken into account. So I think with this I end my talk. Thank you so much.
Thank you, Dr. Sridevi. That was an A to Z complete presentation of a GINA guidelines. Just as you are presenting to your pulmonology group, you have presented. Thank you so much. I don't think anybody will have questions. But only thing is, as a moderator, what I would like to say is, she has told everything this in GINA 2023 guidelines. SABA, she kept on saying is a short-acting beta agonist is only a reliever, but now 2023 recommendations do not admit SABA alone. You have to use an ICS along with it, because, and she put up one study also saying why we should have because down regulation of receptors and all that. So ICS, SABA should be used. So in the beginning itself, you have to use an inhaled corticosteroid along with a short-acting beta agonist like a salbutamol or albuterol, whatever we are saying. And then she talked about even severe asthma, certain things like difficult to treat asthma. And finally, for regarding step 4 and 5, she told about biologics where we can use, and biologics only for a short plan. Then she kept on telling about a treatment action plan and the adherence to treatment. All of us now are, in fact, GINA 2023 guidelines, recommendations, even if you could talk about COPD gold guidelines, all that they are telling about inhaler technique and adherence to treatment. Everything is adherence to treatment. The patient takes whenever she wants, and she doesn't take it when it does not required. It is not so. Otherwise, they will end up in exacerbations. So that has to be looked after by the general practitioners. Every time the general practitioner has to, if he is planned an anti-asthmatic drug for a particular patient, then he has to come and tell me how you are going to use. So adherence to treatment is very, very essential. I think any questions, if it is there, we can.
Yes, madam. Yes, madam. We have 3 questions, madam.
Huh.
Yes, madam. Does GINA guidelines suitable for Indian scenario and phenotype?
Yes.
Yeah.
Sridevi, want to take up that question?
Yes, ma'am. So actually guidelines, I think as you know, they are just guiding us. And we don't have to stick to the guidelines, and then it's all you have to treat the patient the way you look at them. So these are just to make sure you're following the right path. So that should be our aim actually. So these can just because we are using before the formoterol ICS came into place in the GINA guidelines, I think our Indian patients we've been using the ICS much longer before it came into the guidelines. So they just guide us, but it is up to the physician. You can take your decisions. I don't think you should stop from, doing that. You have to take the decisions according to your patient's need. So
1:1. Yeah. Patient-doctor relationship should maintain. Guidelines are there, recommendations are there, but you are going to follow up the patient, so you have to follow him up with your guidelines are there basically, but you can step up. Low dose ICS can be stepped up to moderate dose. All that can be done.
Okay, madam. Thank you very much, madam. Another question. Any treatment modifications in asthma and COPD overlap? Asthma and COPD overlap.
Yeah, asthma COPD overlap. Basically, what happens is patient can be a smoker, but he also has a family history, and probably the spirometry is showing good reversibility. So if at all the patient has good reversibility, you have to treat them as asthmatic itself. So only if at all it is not reversing well, things like that, then you can add on your LAMAs. So all the reversible PFTs should be treated as asthmatic only. You can add ICS+LABA to start off and see if they're responding well. So only then you can consider adding extra medications like your LAMAs and all that.
Okay, madam. Any modifications of asthma treatment in during pregnancy?
See, ICS+LABA, like, the ICS formoterol is very safe, sir, as far as like pregnancy is concerned, because they don't have much systemic absorption. I think it is important to start the treatment throughout the pregnancy. In fact, like, not wait for them to have a serious exacerbation wherein you have to add them on the corticosteroid. I think baseline, when the pregnancy is planned itself, I think it is important to start the patient to start on the low dose ICS formoterol, which is quite safe. And once they are rinsing their mouth, I don't think there will be any systemic absorption. So low dose ICS formoterol, if the patient is having mild symptoms, should be started throughout the pregnancy, and they're very safe. And make sure you're using the patients, telling them to and decreased oral deposition, because anyways in the third trimester of pregnancy, they're going to have difficulties in using a DPI or inhaler directly. So you can advise them to take inhaler with a spacer device. Right from the beginning of the pregnancy, not to stop it totally, at least to, if they have less symptoms, maybe they can use it like thrice weekly, things like that. They're very safe. They don't have much side effects.
Any impact of COVID on asthma?
No, sir. Actually, like, during those times, the studies have shown, because most of the patients were on inhalers. In fact, like, the COVID didn't affect asthma. Like, that were the studies which came up during that time. So it doesn't have much impact, actually. It didn't have much impact. It was almost same as like the normal people's. But most of the asthmatics, in fact, did well because they were already on inhalers, which was kind of like, a sort of treatment for the COVID as well.
Yes, that was correct. We didn't have much admissions due to COVID asthma. In fact, because they were using inhaled corticosteroids and all that, so they were buying. Even though that, I think during COVID, when the pharma companies were closing down, they were not issuing medicine. The patients were all on their inhalers. They used to go and say, I am using this medicine, and used to buy. I didn't have much of deaths during COVID time for asthma patients.
Dr. Jalil has raised the hand. Dr. Jalil, sir, kindly unmute and you can ask a query, sir. Jalil, sir. Dr. Jalil? Okay. There is a question in the chat box about the childhood asthma. Any treatment difference between childhood and the normal patients? What is the dosage in childhood asthma?
Yes, sir. Sometimes I think, like, childhood asthma, like, again, two categories. One is a child who is less than 6 years. So, or between 6 to 12 years. So you can take the entire, like, from birth to 12 years as childhood asthma. So if it is going to be less than 6 years, definitely you have to titrate the dose. So probably you can give inhaler with a spacer, starting, like, with budesonide, 100 micrograms you can start. Just one puff you can give. So one puff you can start off, like inhaler with spacer with a mask you can give them. And till 6 years of age, you're not sure whether they're going to take become an asthmatic, or the asthma is going to subside. So that is the problem. So after 6 years, you can always do a spirometry to confirm whether they're having asthma. So again, like depending, like, if at all after more than 6 years, definitely you can start, like, depending on the severity, once or twice daily you can give the patients. So budesonide 100 mg ICS you can start off, and short acting bronchodilator as a combination you can start off. So usually for kids it is ICS with a SABA. So you don't give long-acting bronchodilators. You have to wait till 12 years. So maybe you can start with ICS and a SABA as a different combinations, but make sure the patient is taking SABA whenever the patient is taking ICS. Until less than 6 years, you don't know whether they're asthmatic, and after that, by doing a PFT, you can titrate the doses accordingly.
One more question, Dr. Rotarian.
Sir, Jayaraman sir, can I, Jayaraman sir?
Please, sir.
Yeah, sir, this is someone has asked about the GINA guideline. We as a pediatrician, GINA is a global initiative. So it is a very standard protocol for universal protocol for asthma management. We always follow the GINA guideline, and every year they are updating also. So there won't be any deviation from the GINA guideline. Madam has highlighted excellent, and all the steps she has mentioned, and the latest SABA along with the ICS also she has mentioned. Congratulations, Sridevi Madam, for your excellent lucid presentation on asthma management. Thank you so much.
Thank you, sir. Thank you so much, sir.
So shall we wind up the session from for asthma? Jayaraman?
Yes, madam. Thank you very much for the wonderful presentation, wonderful moderation. Nalini Jayanti ma'am, a lot of
At the outset,
chat
I
box.
like to thank the organizers as well as Jayaraman for having given this opportunity. Thank you once again.
Thank you, Nalini ma'am, for this wonderful, crisp and clarity presentation. A lot of questions pouring in. So because of time constraints, we'll wind up. Thank you all for this wonderful. We'll move on to the
Thank you,
next
sir.
session on hypertension to commemorate World Hypertension Day. Dr. Sendil Kumar, Sendil sir.
Yes, sir. Ready, sir. Ready, sir.
Yeah, please.
Guys,
go ahead.
welcome to the next session on the hypertension dialogue. Here we have two world-renowned eminent speakers, Dr. Chenniyappan and Dr. Muruganathan. First, I want to introduce Dr. Chenniyappan, sir. Chenniyappan, sir.
Good evening, everyone. Dear brothers and sisters, I am very happy to be here within the IMA Academic AMS wing under the leadership of Abul Hasan, the Secretary Jairam, pulmonologist, and my friend Sendil Kumar. And of course, it was a wonderful talk by Sri Devi and moderated by Nalini Jayanti. Now, we are going to talk about hypertension, very, very informal way. Myself, I am very lucky to have my eminent cardiologist, eminent teacher, Dr. Chenniyappan with me. It'll be like a dialogue. Anybody wants to ask any question, you can put the question on the chat box. It'll be a case-based discussion. It's a day-to-day problems. And we have got about 10 cases. We'll go up to 5 o'clock. And if time permits, we can go finish the 10 cases. Otherwise, we'll stop anytime when we want. Now, we'll open the first question. Yeah, this is an interesting case. Patient number 1. Recently married, 30 years old, male executive of an IT company, a non-smoker, no comorbidities, complaints of severe mental stress at work and fatigue. The BP was 170/110, pulse was 96 per minute, routine blood investigations, ECG, echo within normal limits. Now, in this case, what will you do? Will you give reassurance, or you think it's anxiety, anxiolytics, or start on antihypertensive, or ask him to resign the job? Okay, you can put your questions and answers in the chat box. Next, Chenniyappan, please yes, you can answer okay. And then start.
So here, I think what we have to do is we have to start straight away an antihypertensive, because as you know that what is very important is in this type of patients, it is very important to confirm the patient has got hypertension. For that, you need a good technique, a good preparation of the patient, good technique of a BP recording. Please make sure that a single BP recording, a high BP recording, does not make a diagnosis of hypertension. So you have to have at least 3 readings in a clinical visit, usually 3 to 5 minutes apart, to confirm there's a persistent elevation of blood pressure. So you can ask me, sir, why don't this is a white coat hypertension? But usually white coat hypertension is only in grade 1 hypertension, that is between 140 to 140/90 and above, below 160/100. Whereas when it becomes a grade 2 hypertension more than 160/100, it is most often unlikely to be a white coat hypertension, especially there's a persistent elevation of your 3 readings. That's why you can straight away start drugs when the BP is in the stage 2 hypertension, along with a lifestyle modification. Don't forget about lifestyle modification. So please don't make sure that when the patient has got a grade 2 or stage 2 hypertension, so don't maintain him on lifestyle medication for 3 months and then start a drug.
Yes. In fact, apart from the 3 readings, it is always prudent, like most of the international guidelines says, you also confirm with outside clinic BP measurement, like home blood pressure monitoring.
That's exactly I'm saying, sir. That is primarily for grade 1 hypertension. Yes. So grade 1 hypertension, you have to rule out a white coat hypertension. Whereas especially when there is a stage 2 hypertension, where is a persistent elevation of more than 160/100, or especially in this patient, 170/110, it is unlikely to be a white coat hypertension. So we can start straight away with the clinic BP reading. And of course, we monitor the therapy, a response to therapy with the self-monitoring BP as well as the clinic BP recording. Here we don't, especially the white coat hypertension is ruled out only in grade, majority of times it's only in grade 1 hypertension. Here it is a grade 2 hypertension. That's why I thought we can straight away start the drugs.
And when you start the treatment also, you start with combination therapy, especially
Yeah,
the
we'll come to that quickly later.
Yeah.
So
Now,
the question comes. Yeah. Tell me,
please go ahead.
So the question comes: who is young? Dr. Murunathan is still young in spite of the age, but many people we feel young. But what is the definition of young is between 20 to 40 years. So if the hypertension sets in this year, it is likely to be hypertension in the young. So unlike the various threshold to diagnose a hypertension in middle age and elderly, the young hypertension is equal or more than 140/90. And please remember, you ought to also concentrate on high normal blood pressure, which is between 130 to 189 and 85 to 89. These are the patients who are likely to become hypertensive. So that's why high normal BP cannot be taken as normal. And so these are the patients who are likely to become hypertensive. So lifestyle modification should be put in place whenever there is a high normal blood pressure. Yes, sir.
Okay. See, the very important point here, the presence of hypertension at a young age increase the risk of cardiovascular events in the middle age. Suppose we don't treat hypertension in the younger age, because many a time the young patients do not come for a checkup, they don't care and they don't control, especially the software workers, young boys. It contributes to an earlier onset of coronary heart disease, heart failure, stroke, and transient ischemic attack. Although good national guidelines exist, they do not serve low-risk young patients with hypertension as effectively as older patients. Unfortunately, also, Chenipan, we don't have data on premature hypertension. We always say heart attack comes to India 10 years earlier than the Western countries. Dyslipidemia comes 10 years earlier. Like that, we don't have a data to say the young people develop hypertension in India compared to Western countries. And also, very important point, in a young hypertension, the diastolic pressure is very important, because after 50 only, the systolic is important. The risk assessment is challenging in young patients because we focus on systolic blood pressure is less correlated with cardiovascular endpoints in young patients. That is why a young patient diagnosis is very important. Next.
Yes, the another important point is if the patient is going to develop hypertension at 25 years, he will be hypertensive till 60 years or 70 years. So the duration of the hypertension is very long if the hypertension is at a young age. Whereas the patient is going to develop hypertension around 45 years or 50, his duration of hypertension is not going to be that long. So that's why we have to diagnose young hypertensives, contain the hypertension so that the patient will not develop a future cardiovascular event. So as Dr. Murunathan said, the most important BP in young patient is a diastolic blood pressure. So diastolic blood pressure is more important in the young, whereas the systolic blood pressure is more important in elderly. So now we have a definition of what is isolated diastolic hypertension, where your systolic pressure is less than 140 and diastolic pressure is more than 90. So if you look at the hazard ratios to develop a future cardiovascular event, it is 1.02 for high systolic pressure and 1.35 for high diastolic pressure. So that's why it is more common. Diastolic hypertension is more common in young when compared to elderly. So any young patient with a hypertension, you must always rule out a secondary cause, because secondary causes are curable cause of hypertension. So although there are many secondary causes, we have to remember the most important, this 6 secondary cause of hypertension, which can be remembered by a mnemonic called drop it. T stands for the drug. Many drugs, many times the drug may be producing hypertension. What you have to do is to just take off the drug rather than giving hypertension treatment for lifelong. And a diet rich in fat and salt. R stands for renal parenchymal and renovascular disease. O stands for obstructive sleep apnea. P stands for primary hyperaldosteronism. I stands for inequality of pulses, which can be coarctation of aorta, aorta arteritis, or a peripheral vascular disease. And T stands for thyroid abnormalities. The most common abnormality here in secondary cause will be the thyroid abnormalities. So all hypertensives should have a thyroid function test assessment before starting the treatment. Sir?
Yeah, actually, the another P also we can say pheochromocytoma, but of course that is not that much common like primary hyperaldosteronism. And even the newer guidelines, if you see ACC guidelines, they also says the basic investigation they include calcium also, serum calcium also, saying that, sometimes, parathyroid also can produce a secondary cause of hypertension. Next slide.
Yes. So when you look at the secondary causes, what is a common secondary cause according to the age in a young hypertensive? So in young age, below 18 years, you can see the mid-aortic syndrome or coarctation aorta can be the most common secondary cause, whereas renal parenchymal disease can happen anywhere from the young to the elderly as a secondary cause. Whereas the renovascular hypertension is likely to manifest between 13 and 40 years. And the pathology of a young patient with a renal artery stenosis is different from atherosclerotic renal artery stenosis in the elderly, and it is due to fibromuscular dysplasia. Whereas above 40, the most common secondary cause is likely to be atherosclerotic renal artery stenosis along with a renal parenchymal disease. As far as the genetics are concerned, the monogenic disorders are common below the age of 40. Cushing syndrome is more common after the age of 40. So as Dr. Munadhan said, pheochromocytoma and paraganglioma are common between 20 to 40 for 45 years. And once again, this is the most important primary hyperaldosteronism. I told you one of the importance of 65 years. So this will give an idea what are the secondary causes we have told you and what is the age in which they are likely to manifest. So having seen some of the information about young hypertensives.
Sendil, can you unmute the person who is talking in between? Sendil?
Yes, sir. Sir.
Some disturbance.
Please, yes, sir.
Yes. So now we have decided that this patient, we have evaluated for the secondary hypertension. We have seen some of the important information about young hypertensive. Now, what will be the treatment for this patient? Sir?
Yes. So either beta blocker or diuretic, or beta blocker, calcium blocker, or ARB or ACE. In this particular case, definitely beta blocker is indicated, and the combination of beta blocker and calcium blocker may be the choice.
Yes. See, please remember the latest guidelines are indicating that when you start the first stage itself, you have to start with the initial low dose combination. Initial low dose combination. So previously our actual practices start a particular drug, go on to the maximal dose and then add a second drug. But that is not advised by the latest guidelines. So you have to start two drugs acting in different modes of the hypertension arm and start them at low dose. What we mean by low dose is the half of the original dose. So that's what we mean by low dose. So any young hypertensive, it is preferable to start because we have said this patient is very anxious and is IT professional. So a lot of mental stress will be happening, and that may be contributing to the increased sympathetic flow and hypertension in this patient. And that's why the beta blocker is the first choice. Because we have to start a combination, a best drug to combine with a beta blocker is a calcium channel blocker. Because these two drugs acting on different mechanism, beta blocker is reducing heart rate and contractility, acting on the cardiac output side. Calcium blocker is reducing the peripheral resistance and acting on the diastolic blood pressure. So that's why the beta blocker will produce tachycardia, will act against tachycardia produced by calcium channel blockers, and calcium channel blockers will act against a bradycardia produced by the beta blockers. So that is the best combination. So that's why beta blocker you have to start, but the best combination of the beta blocker is a calcium channel blocker. So the latest guidelines, especially the European guidelines, previous guidelines did not mention beta blocker as the first initial drug of choice, even not a drug in the initial combination. But the latest guideline, especially European Society guideline, have included the beta blocker as one of the initial drugs itself, along with AC inhibitors, ARB, calcium channel blockers, and diuretic. So you can also start a beta blocker in a variety of situations, especially in young hypertensives, in patients who are very anxious and stressful, and people who have got high sympathetic overdrive in the form of tachycardia and sweating, and young females, this is the best drug of choice. And also patient has got a tachyarrhythmia in the form of atrial premature beats, ventricular premature beats. In all these conditions, the beta blockers will help the patient, and it can be in these situations, beta blockers can be started as initial drug. When you start a beta blocker as initial drug, the ideal combination to be combined, because the guidelines are now recommending low dose initial combination. This combination will be the best combination. When you start a beta blocker, the next ideal drug to be added with a beta blocker is a calcium channel blocker, which will have a potentially good BP lowering effect. So,
Chenipan, you said about the European guidelines. Even the recent European guidelines for diabetic hypertension also, you need not start with ACE and ARB. The idea is you have to reduce the pressure. So even the beta blocker also can be taken as a first line drug in diabetic hypertension also, not necessarily ACE and ARB.
Provided there is no albuminuria.
Yeah,
provided
there is no albuminuria.
Yes. Exactly.
If there is albuminuria, ACE and ARB, the drug of choice in diabetic
So
hypertension.
that is the one caveat about diabetes and hypertension.
So what are the lessons? What are the lessons we learned from this? Next slide.
So the beta blocker. So now having
why?
decided a beta blocker, this is a young recently married fellow. So you have to take into consideration all this. And when you want to start a beta blocker and you start a beta blocker like metoprolol or other beta blockers, you can see that the patient may have a problem. So that's why you have to select a beta blocker for this particular patient who is recently married, young, and has got a hypertension due to sympathetic overdrive. And in this, the nebivolol is better because it may not interfere with the sexual activity or an erectile dysfunction. So that's why that lesson from this patient is that this is a young hypertensive. So the young hypertensive has got different type of approach. When you have elderly hypertensive or a middle-aged hypertensive, the type of hypertension is different. And the conditions you have to rule out will be the secondary causes. And you have to see what is contributing to the hypertension. And as I told you, don't ever try a lifestyle modification for initial 1 or 2 months in stage 2 hypertension. In stage 2 hypertension, straight away start the drugs. And of course, you must have some knowledge about hypertension young, especially ruling out secondary causes and what is contributing to his blood pressure and what is his family life is about. And all these things is important because the drug you start not only should control hypertension, must also prevent a future cardiovascular disease, but also should give him a good quality of life. So all these things are important when you consider a drug therapy for any hypertensive. That's why you have to look at the situation, factors contributing hypertension, and address them in totally.
Yeah, always you are always suggest home blood pressure monitoring also for these young patients so that you can confirm your diagnosis. So I always promote home blood pressure monitoring, especially in patients. You have to advise them also to have this home BP. Next,
any questions on this case? We can.
Unfortunately, Chenipan, they cannot ask questions in the chat box. Only it can come.
Yeah, chat box now. I'm just looking at the chat box only.
Yes.
Right. So we go to the patient number 2, and this is a 56-year-old diabetic, obese, postmenopausal lady. Always a problem when this combination is there. Diabetes, obese, and postmenopausal lady. So, and treatment of high blood pressure for the last 4 years, and the patient is on atenolol and thiazide, and the blood pressure is not under control, and the patient also has mild edema. So ECG shows ischemic changes. So this is the next scenario. Now we come to the regular hypertensive we see around 56 years, a diabetic hypertension, just like Dr. Murunathan talked about diabetes and hypertension. So this is the combination of a diabetic hypertensive.
In this case,
yes, sir.
Yeah. In this case, what is wrong is, normally beta blocker and diuretics initial combination, it's not advisable because they both increase insulin resistance. So they can be used if ACE or ARB is already there. If you have any compelling indication to use beta blocker, you can use. Otherwise, beta blocker and diuretics as an initial combination in diabetics is not usually advised.
Yes, that's why it is wrong in this patient because the patient is already on atenolol. The problem with atenolol is not only it increases insulin resistance and worsen diabetes, and also it will further increase weight. So please remember the beta blockers are notorious to increase in weight. So that's why it's very, very important in an obese lady. It is preferable not to use these type of beta blockers, and also the thiazides, which are once again have got a lot of metabolic disadvantages.
Yeah, so now nowadays we don't use Chenipan only in the.
So now having decided that we have to change this combination, what will be the correct combination in this patient? Once again, we have to use a combination as the latest guideline is concerned. So change out AC inhibitor ARB, change out to carvedilol, to try carvedilol or ramipril and carvedilol and diuretic. So here, what is very important is, although you want to stop this atenolol, the patient is on long-term atenolol. So that's why you cannot abruptly stop this atenolol. So that means you have to switch over to a beta blocker, which will not have the disadvantage of this atenolol. So that's what we have to do. The best beta blocker in a diabetic is likely to be carvedilol, because as you know, the carvedilol is alpha and a beta blocker, and is the only beta blocker that does not increase insulin resistance, and the weight gain is very, very less in this patient. But in this patient, this although in the first case I told you the combination beta blocker and calcium channel blocker is the best, in this patient we are not selecting the beta blocker with a calcium channel blocker. Why? Anybody can say why we are not selecting that combination here? So you can always see that the beta blocker has to be started in this patient. Why we should not continue discontinue beta blockers? Because the patient has got some evidence of coronary heart disease. So a diabetic patient having a coronary heart disease, it is very, very important the patient should be on a beta blocker. But that beta blocker should not be interfering with the control of diabetes. It should not mask hypoglycemia, and it cannot be increasing the weight, at the same time increasing the insulin resistance. So all these problems will be there in this type of beta blockers. So we have to use a beta blocker, and we have to use a beta blocker which will not have the disadvantages of the some types of beta blockers.
And
so once
cardio
you
also
decide a
is
beta blocker,
cardio also is good for dyslipidemia. Suppose they have
exactly. Yes.
Yeah, so that's a better.
So here the patient has already got some edema. So when you add a calcium channel blocker here, you can see that the patient may have increase in edema. So this patient has got also coronary heart disease. So you also want to give a patient a vascular protection along with an carvedilol, which is going to reduce the myocardial oxygen demand. You have to select a drug which will not only control the blood pressure, but also try to protect the vessels. So that's why in this patient, this combination would have been ideal, because the ramipril, obesity, metabolic syndrome, and diabetic patient, beta blockers should be avoided as the first initial combination. So please remember, you have to use a beta blocker whenever a diabetic patient has got a coronary heart disease, heart failure, airway dysfunction. So these are the definite indications to use a beta blocker. If you don't use a beta blocker in these conditions, the diabetes, your mortality is doubled. So that's why don't hesitate to use a beta blocker in an indicated patient in a diabetic. And in that beta blocker, carvedilol is preferred. And the combination why we are not preferring calcium channel blocker here is because the patient is obese. The calcium channel blocker will further increase the edema. At the same time, calcium channel blocker will give you the control of blood pressure and may not give you a vascular protection. So we have to add a drug which will not only control the blood pressure, but also give her a vascular protection. That's why, in contrast to the previous patient, we are combining a beta blocker with a RAS inhibitor, which are not only good for the vascular protection in a diabetic, and also it is a nephroprotection in a patient with a diabetes. So that's why we try to use this combination. Yes, sir?
Yes, next, sir, next slide.
Okay. So this is the second patient with a diabetes and hypertensive. So now we come to the third patient. The third patient, yes, sir,
yeah,
you can
yeah,
go, sir.
Yeah, 54-year-old gentleman, a known case of COPD on oral steroids and bronchodilators, present with a BP of 160 by 104. Recently, just before our talk only, you were talking about asthma and COPD and oral steroids. Now, in this patient, how do you manage? Next, next slide. Yes. Which combination is preferred? Whether ACE and calcium channel blocker, or ARB and CCB, or ARB diuretics. Actually, ACE inhibitor is good, but you know, when a patient has got asthma, ACE inhibitor tend to produce cough, and then diuretics will produce dehydration. So the best combination will be ARB and CCB. Next slide, we are going to explanation. Next slide. Yes. Diuretic produces dehydration and thick viscous secretion, blocking small airways. Beta blockers increases bronchoconstriction. And ACE inhibitor, as I said, may increase cough. So calcium blockers have the advantage of dilating bronchi and use inhalation therapy for asthma rather than oral B agonists. Because so far that was a dry home message by the previous speaker, Nalini Jayanti and other Sri Devi. Next.
So that's why the calcium channel blockers will be dilating your smooth muscles. By dilating the smooth muscles of the arteries, they will reduce the peripheral resistance. By dilating the smooth muscles of your bronchi, they can also favorably alter your airway resistance. So the next thing is, so
only thing, whenever there is a compelling indication, when the patient has got COPD with
exactly. So that's what we're coming to the next
okay.
question.
Okay.
So now you may ask me a question, sir. This patient has got a COPD and has got a coronary heart disease. And you already told me that the coronary heart disease, the beta blocker is the first group of drugs. So when the patient has got a combination of COPD and also a coronary heart disease, or this patient has got an LV dysfunction or a COPD with a heart failure. So when there is an indication to use a beta blocker in a COPD patient or an asthmatic patient, what should I do? So that is the next important question, because the patient with a bronchial asthma. So nowadays it is said that COPD patients also die of cardiovascular disease. So the cardiovascular mortality is directly related to FEV1 by FEV ratio. So increasing the airway resistance, increasing the exacerbation of COPD ultimately produces coronary heart disease and cardiovascular death. So like all the patients who are dying of cardiovascular disease, COPD patients also dying of cardiovascular disease. So when the patient has got an LV dysfunction and also coronary heart disease and heart failure, we have to use a beta blocker. And the beta blocker to be used will be either bisoprolol or nebivolol. Because bisoprolol being a pure cardio selective beta blocker only acting on the beta 1 receptor, blocking the beta 1 receptors with a very little effect on beta 2 receptors, the airway resistance is not reduced in the airway resistance is not increased by the bisoprolol, and it can be safely used in bronchial asthma, especially when the patient has got coronary heart disease and LV dysfunction. But some of the COPD patients may have a pulmonary hypertension and they would have come with carpulmonale. In those patients, nebivolol is better, because the nebivolol, by donating nitric oxide, can produce a significant dilatation, and it is one of the vasodilatory beta blockers. As you know, many of the beta blockers are vasoconstrictive. There are only two vasodilatory beta blockers in the form of nebivolol and also carvedilol. But the problem with the carvedilol is we cannot use carvedilol here because the beta blocking component of carvedilol is non-selective. So that means when you use carvedilol, definitely your bronchial asthma is going to be exacerbated. So that's why these are the two drugs. Why we are not using nebivolol in coronary heart disease is the heart rate reduction in nebivolol is not so great as bisoprolol. Because in coronary heart disease, what is very important to reduce the heart rate, to reduce the myocardial oxygen demand. So we hesitate to use nebivolol in patients with coronary heart disease. And also we have very little evidence, a very small evidence only for heart failure. So we select between, along with the COPD, what the patient has got, whether it is CAD or LV dysfunction, it's bisoprolol. He has got a pulmonary hypertension. For example, some of the patients may have independent pulmonary hypertension, not necessarily a carpulmonary. They can have a systemic hypertension, also pulmonary hypertension. In those patients, we can select nebivolol. Sir?
Yes. Next point, sir.
Right.
Lesson
so that's
3.
why the lesson 3 is that when...
Shall I go ahead?
Sure, sir.
Comorbidities should be always seen before prescribing antihypertensives. For example, somebody has got coronary artery disease. You must select a drug which is good for hypertension as well as reducing the comorbidity. Our aim is not only to reduce their blood pressure, also look for the comorbidities. Suppose we want to de-escalate, suppose the patient's hypertension is under control, then we'll think about de-escalation. De-escalation also, you should not reduce a drug which reduces even producing prevention drug. So for example, when you have ACE inhibitor and beta blocker, ACE inhibitor is an even reducing drug. So you cannot reduce the ACE inhibitor. Like that, Antihypertensive drugs should not be aggravating comorbidities and interact with those drugs. Even the drugs which we think are contraindicated should be used in certain situations with better molecules. For example, in asthma, beta blockers are contraindicated. But still, when there is a compelling indication like heart failure or angina, you will have to use a selective beta blocker, vasodilatative beta blocker like bisoprolol and nebivolol. Jennifer?
Yes, sir. Next patient, sir.
A 75-year-old gentleman, non-smoker, non-diabetic on treatment for high blood pressure in the last 2 years with Ramipril, comes to OPD with BP of 180 for 70. Serial BP shows this pattern persistently. This is a case of isolated systolic hypertension. And if you think this is systolic hypertension, elderly person, what is that? What are the steps you do? First, you have to, especially in elderly person, you have to rule out postural blood pressure and then rule out pseudo hypertension. So by postural hypertension, Jennifer, can you go ahead or
Yes. So this is what I told you before you start a drug, before you increase a drug, or before add a drug in any elderly patient, always check the postural blood pressure. Postural blood pressure is checked by asking the patient lie down quietly for 5 minutes. Then the patient stands. The first minute blood pressure is taken immediately. Then the first minute and also the third minute. So the 3 blood pressures are taken on standing. So the fall of blood pressure of equal or more than 20 systolic and equal or more than 10 diastolic is defined as postural hypotension. So this is very, very important to understand that if the patient has got a significant postural hypotension, this will produce a stroke, syncope, and fractures, and very dangerous situation. So that's why anytime you want to these 3 things, so you must look up for the postural hypertension, and you have to make sure there is no significant postural hypertension before you start a drug. Sir, you want to tell us the lossless maneuver?
Go ahead.
Right. So what happens in elderly, the other problem is that the patients may have thickened arteries. So whenever the patient has got a thickened artery, let's say the patient has got a thickened, very thickened brachial artery, then what happens is you have to increase your systolic pressure in the cuff to occlude a very thick artery. So it will show you a very high systolic pressure, which is not indicative of increase in intraluminal pressure. You are increasing the systolic pressure to occlude a very hardened artery. So this systolic pressure is called pseudo hypotension, and this pseudo hypertension is diagnosed by making the systolic blood pressure above the value of a significant systolic. You have to increase the systolic pressure significantly and feel for the artery. Normally, when you increase the systolic pressure in the cuff, the artery is not palpated. It will be collapsed. But in spite of increasing your systolic pressure, if you feel an artery like a nerve or a cord, that means it is a thickened artery. So this is called positive oscillus maneuver. So increasing the systolic pressure, you don't have the collapsed artery, but you have a palpable artery. That means you are exerting more systolic pressure by the cuff to occlude a hardened artery rather than increase in systolic pressure in the lumen. That's why here you don't start an antihypertensive drug. Whereas when you increase the systolic pressure and the artery is not palpable, that means it is a truly increased systolic pressure in the lumen. Yes, sir.
What is postprandial hypotension, Jennifer?
Yeah, postprandial hypotension is the hypotension which happens after a heavy food. So it's usually majority of your patients may be telling you that I feel very tired. I want to sleep after a meal. I feel very tired after a meal. In those, especially in diabetics, you have to get the postprandial hypotension. And the important thing is the postprandial hypotension peaks around 30 minutes after food. And it is because of the splanchnic vasodilatation. It is a significant vasodilatation happening in the gut. And it's got an equal pathophysiology like a postural hypotension. In postural hypotension, your blood flow is pooled in the legs. Whereas in a postprandial hypotension, the blood flow is pooled in your gut. So
actually,
anyway,
this fall is like 20 millimeter, and it can be from 30 minutes to...
There is no diastolic fall. It is only a systolic fall. In postprandial hypotension, it is only a systolic fall of more than 20 millimeters. It can maximally happen around 30 minutes, but it can go up to 3 hours. So what happens is it is just like the brain is not getting the blood supply because the blood is, instead of pooling in the legs, it is pooling in the gut. So in these patients, what you have to do is we ask the patient take a lot of water before they take a meal. They have
At least
to
half liter of water they should
yes,
take
exactly,
before meals.
exactly. And they do not stand immediately after taking the food. So they have to sit for some time, and they do not take a large meal, and they do not take a large carbohydrate meal. So all these things are important to prevent a postprandial hypotension. So especially in a diabetic, when the patient is complaining of severe tiredness or drowsiness after taking food, always check the postprandial hypotension.
Yes.
So this particular BP is not only high systolic blood pressure, it is also high pulse pressure hypertension. Here you can see the BP is 180/70. 180 is high systolic, 70 is low diastolic, lower level of diastolic blood pressure. Why this is above all blood pressures? This is the most dangerous blood pressure. So high systolic and low diastolic is the most dangerous. Then comes isolated systolic hypertension. Then comes systolic and diastolic hypertension. Then comes the isolated diastolic hypertension. Why this is more dangerous is increase in systolic blood pressure means the heart has to pump against so much of resistance, so it increases myocardial oxygen demand. Whereas the coronaries are getting filled in diastole because of your low diastolic pressure, the coronary filling is reduced. So it increases this type of blood pressure. If this type of hypertension is going to increase your myocardial oxygen demand and going to decrease coronary artery supply. So that's why it is most dangerous. So now we have this blood pressure. So what is your option? Adding a diuretic or adding a calcium channel blocker? Because this patient is already on a ramipril. So the BP is still high. So what is your option? So there are two options, either using a diuretic, sir, you want to take up?
Usually in the elderly hypertension, diuretic is the first preferred drug. But in this case, adding CCB is better. Which can we go to the next slide?
Yeah. So adding CCB is better because of this.
CCB and ACE reduces pulse wave velocity by reducing aortic stiffness. In this way, they reduce systolic blood pressure and increase diastolic blood pressure. But the popular question people will ask, suppose in a systolic hypertension, you give a drug that reduces systolic blood pressure and the diastolic also is reduced. Suppose in this case 70, if the diastolic is reduced to less than 70, the coronary blood flow will be affected. So are we reason enough to give the drug to reduce systolic blood pressure? Always Chenipan answers this question, and this is evidence-based. The CCB and ACE reduce pulse wave velocity. So if you see the central aortic pressure, the augmented index also is reduced, and it also reduces the increases the diastolic blood pressure. That's why you safely can do. The lesson is in isolated systolic hypertension, where the pulse pressure is more, that is the most dangerous, and we must take care of this. So elderly isolated systolic hypertension, thiazide diuretics, I already told you, for the first line. But in that case, calcium channel blocker. Chlorthalidone is better than the hydrochlorothiazide. But if there is a high pulse pressure, combination of ACE and CCB, where in that case, the previous case, always check positive blood pressure before starting, adding, or increasing drugs in the elderly. And then rule out pseudohypertension before starting therapy. There are so many causes of pseudohypertension. One of the elderly patients is Astley's maneuver, which you have to see. Next.
So that's why systolic blood pressure increase in elderly is not viewed as a isolated systolic hypertension only. So when you have a high systolic pressure in the elderly, what you have to see is what is his diastolic blood pressure is. If he has got a normal diastolic pressure with isolated systolic pressure, thiazide is the best. But if you have a high systolic pressure but a low diastolic pressure, then this combination is better.
Now the patient 5, a 50 years old hypertensive diabetic lady with severe osteoarthritis knee presents to the OPD with facial puffiness, pedal edema, and a BP of 210/150. Till last month, BP was under control. No acute emergency clinical presentation. It's only hypertensive urgency. You know what is the difference between hypertensive urgency and emergency? In a hypertensive urgency, there is no target organ damage where the blood pressure is more than 180/120. If there is a target organ damage with 180/120, it is called hypertensive emergency. Next. So anybody
So
take over?
anything between 180/120 is hypertensive crisis. Hypertensive crisis, as Dr. Mulan put, if the patient comes with acute pulmonary edema, acute stroke, or acute kidney injury, or acute dissection, it is an emergency. Whereas with this blood pressure, the patient is walking into your office with a slight headache, it is hypertensive urgency. So that's the difference. So many times what we see in many of our patients is, especially in elderly patient. So what is the important why the BP is getting out of control in elderly patients will be, they may be abruptly stopping the drugs, that they may have developed a kidney kidney disease. They may develop atherosclerotic renal stenosis. So this is a patient with the osteoarthritis. So please make sure whether the patient is on NSAIDs, steroids, and if the patient is asthma beta, oral beta agonist. So diet may be abnormal, or they may be having depressed mental stress in this age. And most important thing is to look at the obstructive sleep apnea. And many times the high systolic and low diastolic pressure, as we mentioned in the last case, always rule out an aortic regurgitation. So in the presence of atherosclerotic aortic regurgitation, this type of blood pressure may happen, because typically a significant AR will produce high systolic and low diastolic blood pressure, high pulse pressure. Another thing is faulty technique and some type of fluid overload. All these things will make a previously controlled blood pressure go into out of control. Yes, sir.
See, whenever there is an osteoarthritis, we have a tendency to use NSAID. So non-selective NSAID increases systolic blood pressure by about 7 to 10 millimeters of mercury, diastolic blood pressure by 3 to 4, the mean arterial pressure by about 6 millimeters of mercury. The increase in BP is greater in patients with hypertension compared to normal patients, normal tension patients. And in those treated with the ACE inhibitors, diuretics, and beta blockers. Then what is the best drug in a patient with hypertension with on NSAID? The calcium channel blocker is the best drug. And if they have, if they can change the lifestyle and change over to some other drug instead of NSAID, that's one way of controlling the blood pressure. Otherwise, usually in a patient with hypertension who is taking NSAID, calcium channel blocker is best. The mechanism of retention of salt and water, renal vasoconstriction through blocking of renal prostaglandins, blocking ACE inhibitor. That is the mechanism. Why NSAID and high blood pressure? That is because of the retention of salt and water, and that also causes renal vasoconstriction, blocking the renal prostaglandins and blocking of the ACE inhibitor. The common causes of accelerated hypertension and heart failure in a patient who has taken who's got osteoarthritis, who's taking NSAID, who's already hypertensive, suddenly the blood pressure may go up. So this is the common cause of accelerated hypertension and heart failure. So please keep in mind, NSAID is one of the interfering drug to produce a lot of problems like this in elderly patients. That is why in the long run, we always tell them to reduce the high weight and then give them some disease modifying agent instead of NSAID in a hypertension for a long phase, long time chronic hypertension with osteoarthritis. Next.
So that's one more point about this sentence. You may wonder why the patient is on ACE inhibitor and a diuretic should have increased blood pressure on NSAID. So it is understandable why it may not act. ACE inhibitor may not act, diuretic may not act. But in these patients, when you give NSAID, the BP increases. So that's a very, very important problem. It's called triple problem. When you add an NSAID without knowledge of this patient having ACE inhibitor and diuretic, what happens is the ACE inhibitors is actually producing the efferent arterial dilatation, and thereby it is protecting the kidney. Whereas diuretics are trying to eliminate sodium and water. But the NSAID will reduce prostaglandin and it will significantly control afferent arteriole. So now it is going to block also the ACE inhibitor. So afferent ACE inhibitor there will be a significant reduction in GFR, and the patient will go for, and the diuretic will further producing hypovolemia and increase sodium. So this patient will go for AKI, acute kidney injury, and that's why the BP is significantly increased. That's why you have to be very, very careful when you add a patient with ACE inhibitor and ARB and especially with the diuretic, if you add your NSAID, it is going to be very, very dangerous. As in a CKD patient, if you are not able to use ACE inhibitor ARB, if your creatinine is going up more than 30% of the baseline, potassium is more than 5.5, or today the latest recommendation, eGFR falls, GFR falls more than 15%. In those patients, you cannot use ACE inhibitor ARD. So next, in a CKD, the next drugs where you cannot use the ACE inhibitor ARB will be calcium channel blockers, alpha blockers, hydralazine, alpha methyl-dopant, clonidine, or those antihypertensive drugs we can use in a CKD, or the patient is on NSAID. These drugs may work and these drugs may not work. So the calcium channel blockers are exactly acting opposite to the NSAIDs by producing renal vasodilatation and natriuresis. So the lesson 5 is whenever the BP is going out of control, you have to think of certain things. And many times we think we label a patient as essential hypertension. For lifelong, he remains essential hypertension. Please remember, at any point of his life, there may be a secondary cause which may be added on to the existing primary hypertension, and the patient's BP can go out of control. So we cannot put a primary hypertension and a secondary hypertension in two separate compartments and see this is going to be primary hypertension for lifelong. So always a simple example is an elderly patient, suddenly the BP is going out of control, maybe due to atherosclerotic renal artery stenosis. So a secondary cause superimposed on a primary cause. That's why it is very, very important to look at, although you have been treating that patient as essential hypertension so long, there may be add on a secondary cause, like a drug, as I told you, NSAID drug. So additional drug the patient is taking. And the very important clue is whenever your diastolic pressure is above 130 or 140, the most common secondary cause is going to be a CKD. A very high diastolic pressure is produced by CKD. Sir?
And also in that, one more lesson, adherence, especially non-stopping, stopping the drugs abruptly also is one of the causes in elderly. Many times that is the most important cause for sudden rise
that's
of
the
blood
first cause we have mentioned as the first important cause of suddenly going out of control.
So that is one of the important thing with whenever somebody is having high blood pressure, ask them whether the adherence is correct or not. Now the sixth patient, a 45-year-old obese gentleman weighing 110 kilos with history of intermittent dyspnea, snoring at night and daytime, sleepiness, presents with BP of 160/106. You know the mechanism how obstructive sleep apnea produces hypertension. It can be through nocturnal fluid shift or renin-angiotensin-aldosterone system, or through impaired autonomic nervous system and effect of hypoxemia or impaired quality of sleep. Yes.
So the most, I told you, the most important for today's history includes a sleep disordered breathing. So we take a routine history, but we never ask about sleep disordered breathing. The sleep disordered breathing is starting with a simple snoring. A simple snoring, obstructive sleep apnea, a severe type of apnea where the patient gets up in the night. So all these things are very, very important in a routine history in a patient with hypertension. And please remember, it is not as if only obese patients are going to have obstructive sleep apnea. Even lean patients can have obstructive sleep apnea because of some abnormality in the upper airway and because of a large tongue and or large adenoids. Even a lean patient can have obstructive sleep apnea. So routine question in today history taking is snoring, and also asking the partner whether the patient has got. So when you ask the patient whether the patient is snoring, and another important question is when the patient is snoring, whether his loudness of the snoring is going high and high, whether he stops breathing for brief 1 or 2 seconds. The patient may not get up with a dyspnea, but this type of history, the patient is stopping breathing, and the partner will say, "I'm so afraid, sir." It's as if he's stopping breathing for a few seconds. So this is typically obstructive sleep apnea, and you have to do a sleep study. And the sleep study, if apnea, hypopnea index is, if it is indicated, then you have to give a CPAP. So the next question comes whether CPAP will reduce your blood pressure. So there are some evidence to say that your 24-hour systolic and diastolic blood pressure is reduced. But greatest benefit of CPAP is the reduction in nocturnal systolic blood pressure. So many times we talk about the most important BP is the nocturnal blood pressure. Dr. Murunal has given many lectures on nocturnal hypertension. So the dipping and non-dipping. So one of the important causes of nocturnal hypertension is sleep apnea. So that's why it's a very good method of choice to reduce the nocturnal blood pressure. And the nocturnal diastolic blood pressure has got no significant impact as far as the CPAP is concerned, but the nocturnal systolic blood pressure has got a huge benefit.
But for a female, the CPAP doesn't work like male. It is little less than the effect. Do you agree, Chanipan?
Yes, yes.
In a female with OSA, the CPAP, it may not be, the level indication is 2A, I think, in the
yes. So the CPAP itself has got only a moderate impact. It may not, we cannot say a significant impact. It may not have a significant clinical event reduction. It may help you to control the blood pressure, control angina, and control heart failure, along with other therapies. If you miss that, you may not able to effectively control. So the CPAP may be an adjuvant for already existing your guideline-directed medical management in these conditions.
Yeah. So the lesson learned here, in obese, difficult to control hypertensives, always look for sleep disorders, sleep disorder breathing, very important cause of resistant hypertension. If you see many resistant hypertension in our setup, you must ask this history from the spouse, whether he is snoring, whether there is any signs or clue for the OSA. Again, in the OSA, the best drug, always, Chenipan used to say, spironolactone, the MRA. Why it is important? Because it not only reduces the blood pressure, it reduces the upper pharyngeal edema. So whenever he sleeps, the redistribution of fluid from the feet to the upper part, there is a edema in the upper pharyngeal. So spironolactone not only reduces the blood pressure, it also reduces the edema. That is why that drug is very good, especially in a resistant hypertension due to OSA. The ideal drug is spironolactone. If there is no hyperkalemia, this can be used safely. Avoid drugs which will increase weight and sedation. Use drugs which act against insulin resistance and hyperaldosteronism. And of course, SGLT2 inhibitor may be preferable. Now, the patient 7, I think we'll stop with this 7. We'll finish Chenipan, and then we can stop. Sendil?
Yes,
Shall we go ahead? Sendil Kumar?
Sir, we can stop with the case. 7th case, we can proceed and stop, sir. Thank you, sir.
Okay,
Thank you, sir.
Okay. Right. A 50-year-old non-smoker, non-diabetic with high blood pressure for 15 years duration on metoprolol and amlodipine comes for treatment for high blood pressure, presenting BP 150/100. ECG shows LVH with strain. Echo shows concentric LVH. Blood tests are normal. Urine albumin trace. In this case, you think the combination is good because the patient is taking, patient has got LVH and albumin. Beta blockers and amlodipine are not good drugs for regressing LVH. Both drugs don't reduce proteinuria and prevent future CKD. So the better drugs to reduce LVH is ARB, especially losartan. And these are the drugs which produces LVH, the diuretics, beta blockers, calcium antagonists compared to ACE inhibitor and angiotensin II receptor inhibitor. The best is ARB, and we always prefer losartan. Chenipan, you had...
Yes. So the ARBs are the best drugs to regress LVH. For example, the patient has got a high blood pressure and a hypertension-mediated organ disease. Your aim is not only control the blood pressure to the target numbers, but also address what is hypertension-mediated organ disease and regress that. So, for example, LVH and blood pressure, don't aim to control blood pressure to 130/80, but also aim to regress LVH, also aim to reduce your albumin. So they have to select the drugs like that. So in the LVH, the best drug of choice to regress LVH is angiotensin receptor blockers. And what is very important to see that when the patient has got a LVH by echocardiogram and electrocardiogram, and what is very important that it may take 6 months, more than 6 months for the LVH to regress. But when you regress LVH, there is a significant cardiovascular benefit. So that is the importance of selecting a drug, not only controlling the blood pressure, but also waiting for these drugs to control, not only controlling the blood pressure, but also waiting for the LVH to regress. When you are able to regress the LVH because of this particular drugs or the combination, you have a significant prognostic value. So that's why now the blood pressure treatment is not the numbers. We have to see whether there is a hypertension-mediated organ disease and trying to regress hypertension-mediated organ disease with appropriate drugs and their combinations. So this is just, I just added to give you, when you are using two drugs, the most important question is asked, whether what drug to be given in the night or in the morning. So the latest guidelines are saying there is no definite guideline regarding what drug to be given in the morning and what drug to be given in the evening. So if you are make sure that the drugs are acting for 24 hours and you give it in the morning, it's good enough. Make sure that the drug is 24-hour acting. But most often what we practice is to give beta blocker and diuretics in the morning and give calcium channel blockers and ARBs or AC inhibitor in the night. But one calcium channel blocker, one beta blocker which can be given in the night is carvedilol, especially for non-dippers. And many times when because of the calcium channel blocker, patient may complain of increased urination. In those patients, a calcium channel blocker may be shifted to in the morning or in the noon. So this is the treatment. So, sir, you can conclude this.
Yeah, in treatment of hypertension, the lesson, 7th lesson, what we learned from the cases, one should not only lower the blood pressure in numbers, but also regress HMOD. As Chenipan said, when you regress HMOD, the future problems also reduce. So not only reduce the pressure, you also reduce the HMOD, such as albuminuria, by appropriately selecting drugs. By reversing HMOD, future CVD events can be reduced or prevented.
I'll go to the last, this is the last slide.
Yes.
So we have put on some patients. So in this, what is very important in the treatment of hypertension is to understand the patient first, then understand the disease, and then understand the drugs. So when you understand all this, only you can select an appropriate drug or the combination, which will not only help the patient, but also favorably alter the disease progression, but also by using a good drugs, you will prevent a future cardiovascular event. So that's why it is very important to concentrate on all this area. For the patient is obese patient, snoring patient, the disease is whether the patient has a HMOD or not, secondary causes or not, and the drugs, which drug will regress LVH, which drugs will act for CAD. So all this information is important for the holistic management of hypertension. And most important is by understanding this, you try to get the target blood pressure and regress HMOD and maintain the target blood pressure for lifelong, so that you reduce future cardiovascular events like heart failure, coronary heart disease, and stroke.
I think the drive-home message for all of you is, you must understand the disease, understand the drugs, understand the patient. More than that, you must also use home blood pressure monitoring to, that's my favorite thing. So you always, tell your patients to empower the patient in the treatment, and then clinician inertia should be avoided, and make sure the patient gets adherence to the drug. So these are the follow-up measures for controlling the hypertension. And I think the World Hypertension Day, know your number, control hypertension is the theme. I think we will meet again on 17th May. That is the World Hypertension Day, if possible. And we'll have one more session on hypertension. And I thank Dr. Chenipan, who has prepared the slides and, done the dialogue. And I also thank Dr. Jairam and Sendil for having requested us to do this program. And I thank everyone. I think if there is any question, please, write to our WhatsApp groups. We have, all of you are in our WhatsApp group only. Most of you are very well known to us. So send the questions, we will answer. Thank you once again, and over to Jairam.
Thank you very much, sir. We had a wonderful discussion to commemorate World Hypertension Day. I thank you, Chenipan sir. I thank you, Muruganan sir, for this wonderful highlight on the hypertension control, dialogues on hypertension. We are all enjoyed a lot of take-home messages. You beautifully presented both Chenipan sir as well as Muruganan sir with the case presentation. So very, very useful for all our members to benefit. Lot of case scenarios. From the respiratory perspective, sleep apnea is one of the secondary cause of hypertension. So snoring is one of the common disorder. Only thing is, it's a very much under-recognized, under-diagnosed conditions. So most of the patients, they have 2 pills, 3 pills for hypertension. So without asking any history of sleep and sleep disorder breathing. So both Chennippan sir as well as Murugan sir highlighted all about the hypertension and snoring. So OSA, all important secondary cause of hypertension. Thank you very much for this wonderful. You are all really beast of medicine. There is no doubt at all, sir. Murugan sir, thank you very much. Thank you, Chennippan sir. We had a wonderful discussion. Because of time constraints, we want to have one more May 17th, one more talk. I'll discuss with my chairman. I will update you, sir.
Sir,
So thank
everybody
you all for this.
messaging.
Yeah,
Sir,
please.
everybody is messaging. Also discuss the 3 more cases in Portugal, sir.
Yeah. Ama. It's a mesmerizing talk.
No,
Appadi and the normal way appadi irukanga.
No, Jairam, we are ready because we have got 20 cases, not
Wow.
7. We have 20
We
cases.
can have one more session, sir. We can have one more session.
Definitely. Hypertension is one of the.
Sir.
கண்டிப்பா பண்ணணும். நல்லா இருக்கு. ரொம்ப சூப்பர் டாக். Thank you, Murugan sir. Thank you, Chennippan sir. For this wonderful valuable time spent on this IMA platform. You're all stalwarts. Thank you very much. God bless. Long live CCS. Long live IMA. Thank you very much, sir.